Welcome to the Wow MD podcast, where in each episode you will get in 30 minutes or less valuable pearls about holistic wellness, anti-aging, hormone therapies, beauty trends, and other facts you should know about our medical healthcare system and your health that no one is telling you. My name is Dr. Mirala Chernayanu. I am a conventional board-certified OBGYN physician who, after the loss of my father due to a careless and uncaring medical team, decided to retrain and seek certification in anti-aging and restorative therapies. What I know, I am happy to share with you. Hello, and I am going to start today's episode, the last in this series of breast cancer surveillance. And I'm going to reassure you it is the last. And you have probably heard enough about breast cancer surveillance in the previous 3 episodes. However, there's a lot to be said about this specific topic that, unfortunately, I just have a little bit more information for you in today's episode. Now, obviously, in the previous 3 episodes, I spoke about mammograms, the mammogram risk, the radiation risk of mammogram, the unintended harm risk. I spoke about alternative testing modalities, breast ultrasound, MRI, thermography. I spoke a little bit about the relationship between hormone replacement therapy and breast cancer. I ended my 3rd episode on this topic, reminding all my listeners about the value of testosterone therapy as being the exact opposite of estrogen when it comes to proliferative effects on the breast tissue, as it has the opposing, shrinking, protective action on a breast tissue cancerous change. Today's podcast is the last in this series, so I do want to start right off the bat by introducing the idea of the breast exam. It is still very important. I didn't have a chance to talk about it earlier. And I kind of want to talk a little bit about the comparison between the pap smear and the breast exam, because many women believe somehow that it's more important for them to have a pap smear than it is to have a breast exam. And then I'd like to mention that there are newer tests existent out there, specifically blood testing, which can detect early cancer. And this is where our research should really lead. We have come up against the wall. There has been no further progress in detecting breast cancer if the best we can do is just advise women to have an annual mammogram. And then I will end the podcast with a few musings on why breast cancer is so feared by women, even though it is such a highly curable cancer. So, as I mentioned in the intro, breast exam done either by a woman periodically or by a physician once a year or as needed to address a woman's concern is very valuable. In today's episode, I'd like to remind all the female listeners and their spouses, if they're listening, that monthly breast exams or any periodic exams, or even quarterly, are very useful in picking up early abnormalities. And in case you didn't know, 40 to 50% of breast cancers are self-diagnosed. So they're picked up by the actual woman. They are not diagnosed by mammograms. They're simply diagnosed by the woman herself when she finds something in the breast. Most of the time, it's a small lump or a little something, and she's not sure. She comes to the doctor. The doctor's like, yeah, I agree. Let's do an imaging test to confirm it, and here it is. Now, everyone knows how to do a breast exam, even though they believe they don't know how to do a breast exam. And many times, I hear women say, well, I don't really know what I'm looking for. Well, it's very simple. You're looking for anything that's outside of your normal, regular self-exam findings. And if you keep doing your breast exam regularly, you are going to get used to what your breast feels like. You will know what your normal is. This means your breasts will feel a very specific way to you, and you will get used to how it feels like. If you pay attention to it once a month, then anything out of the ordinary is a signal to come in and confirm it with a physician assessment, followed by a diagnostic imaging order. Nowadays, many women are completely bypassing the annual breast exam done by a physician or a provider, and they simply think, well, a mammogram is sufficient. They even call the office asking for the mammogram order because, hey, it's time to have that mammogram, and you get that notice from the imaging center, and they either forget or they do not know that 10% of breast cancers are not going to be picked up on a mammogram. Please do not discard or ignore the importance of an annual breast exam performed in the doctor's office, preferably at the same time you're going to get a pelvic exam and a possible pap smear. I would like to add a little bit more information illustrating the importance of a self-breast exam and an annual exam performed by a medical professional, because many women are not necessarily getting their annual anymore. A specific patient case comes to mind that I'm going to share it with you today. A few years back, I saw this woman who was the single mother of 3 children who came in for annual checkup and a hormonal consultation. She had been diagnosed with stage 3, pretty advanced breast cancer, because she did not go to any doctor to have an exam of her breast for 3 years. And obviously, she didn't do any self-breast exams. She was probably very busy mothering her 3 children and probably working. She unfortunately went in for a routine physical, and it was very late. Her cancer was diagnosed in an advanced stage. She was in her early, I think, not even mid-40s. So the mammogram was never recommended, as she did not see a doctor for an annual exam for 3 years in order to recommend it. So when I asked her, I said, what happened? How come you didn't have your annual physical exam, and how come this didn't get picked up for 3 years? She said she was told she does not need a pap smear for 3 years. And in her mind, this equated to no need to see a doctor for 3 years. So please do not associate the need for a pap smear with the need for an annual exam. They're not the same. Even if you are told you do not need a pap smear for 3 years, Kaiser doesn't even do them for 5 years. You will still need an annual breast exam, an annual pelvic exam, and please do not believe you should only have a breast exam when you're due for a pap smear, which is 3 years or 5 years. I encourage you to have an annual physical done by an experienced physician, which includes a breast exam once a year, and you should do your own self-exams once a month, whether you're naturally cycling or you are already menopausal or postmenopausal. The best time to do your exam is right after your period in that first week. And if you are menopausal, just consider doing your exam on the first week of the month, every month. I do believe more voices like myself need to talk about this, because we need to change the narrative of the well woman exam. It's all around the pap smear. It is not. And this should not be the focus of a well woman exam. I'm going to talk in a future episode about pap smears when I talk about the overall risk of cancer and what kind of cancers should we screen for in an annual exam. Cervical cancer, breast cancer, lung cancer, colon cancer, etc. And I will talk about the focus of the annual exam and the screening in general, but for the purpose of today's episode, I want to provide you with some numbers that I hope are going to put things into perspective for why we need to change the narrative from the focus on the annual exam being on the pap smear to the focus being on the breast exam, pelvic exam, and overall cancer screening when a woman has an annual checkup. Let me provide a few statistical numbers so I can illustrate my point. Cervical cancer has an incidence of 7.5 cases per 100,000 women. Compare that to breast cancer, which has an incidence of 130 cases for 100,000 women. So cervical cancer, 7.5, breast cancer, 130. Or lung cancer, incidence of 55 cases for 100,000 women, or colon cancer, 31 cases per 100,000 women. We are doing the women a disfavor by focusing on time to get the pap smear. No, it should be called time to get the annual cancer screening. It is true that cervical cancer incidence peaks in women aged 30 to mid-40s, but breast cancer incidence and breast cancer risk will increase as a woman gets older, especially as she enters and lives her life through the decades of menopause and postmenopause. And that's the same and is true also for colon cancer, as the average age for diagnosis of colon cancer is 69 years old in women. A little bit different for lung cancer, as there seems to be a recent rise in lung cancer among women aged 35 to 54. while the traditional peak for overall diagnosis is normally 65 to 74. I will talk about this more when I discuss this topic in an upcoming episode. I'm still focused on the annual screening, so I'll continue this series. But today is the last one, I promise, about breast. So what you should know is that a well woman covered by your insurance plan unfortunately covers a very basic breast exam, a basic pelvic exam, the performance of a pap smear, and a very basic ordering of blood tests, including the mammogram, maybe a bone density, and maybe a Cologuard. Very, very limited. I personally try to do as comprehensive an exam as possible, and I like my nurse practitioner to do those because she has much more patients than I do. Even though I'm more experienced and super fast at this, the woman needs time to spend with her provider. But most of the time allotted for these exams is usually 20 to 25 minutes, and that includes the admin time for the doctor to document and place the orders as well as arranging for follow-up. And unfortunately, this short time dedicated to such an important visit is driven by the low reimbursement, which is just around $100. And unfortunately, women will get what their insurance plan pays for, which unfortunately is very little and very limited. So last but not least, while we have a very effective screening method for cervical cancer, which is detecting precancer early, and it is actually helping us to reduce the incidence and risk of cervical cancer, keep in mind there is no such similar screening method for breast cancer. The mammogram will unfortunately not screen and detect precancer changes. Therefore, a mammogram once a year will not give you the opportunity to act on precancerous lesions or changes to prevent mammogram. What a mammogram does is simply picking up a breast cancer early on, early enough to save your life. So, as the science of longevity advances, we need to come up with a better screening method that would actually detect precancerous problems, precancerous changes, which could potentially turn into cancer, allowing both the woman and the physician a plan of action, keeping the woman from a collision course with this terribly, intensely emotionally charged diagnosis. The breasts are a symbol of a woman's femininity. I made this point in another podcast that women are much less attached to their uterus emotionally than they are to their breasts. Even though breast cancer is a highly survivable cancer, the diagnosis of breast cancer will, in today's day and age, still condemn the woman to a surgical excision, either partial or total, of one or both breasts, will condemn her to inability to use hormone therapy for menopause, and will subject her to likely chemotherapy or radiation or a combination of these, as well as hormonal therapy targeted to inhibit hormone-sensitive cancers. All of these have way too many side effects and complications, which unfortunately make women's lives miserable. The treatment for cancer can and will increase the risk for very specific morbidity and mortality, which has nothing to do with the actual cancer. This is what I talked about earlier in episode 2 when I discussed mammogram risks and unintended harm. So visit that episode for more details on that. Now, I do believe we need to focus our attention on other imaging technology, or better yet, on alternative detection techniques with circulating DNA blood testing markers, tumor markers, inflammatory markers, hormone balance markers, tests focused on detecting exposure to endocrine receptor disruptors, which this specific area that's actually highly involved in causing breast cancer has been largely ignored, but probably the reason for the substantial and staggering increase in breast cancer incidence and breast cancer risk, particularly in countries like the United States. Why? Because most likely we have decided to forsake quality for profit when it comes to food and agriculture. There's been a lot of focus on huge revenue generated by consumerism instead of protecting our environment and our food chain. So our food chain has been hijacked. We all know that. We all agree on that. We have sacrificed much that we do not completely understand for the sake of convenience. And all you have to do is compare the risk of cancer, any cancers, today with what it was 50 or 70 years ago. The medical community has been blaming hormone menopause therapy for 2 decades now, condemning millions of women to decades of suffering as they have aged and continue to age in the belief that by foregoing hormone therapy, they are protecting themselves from breast cancer. The truth will always surface, and the truth is our hormones, estrogen, progesterone, testosterone, are not to blame for breast cancer. These hormones, especially estrogen, the goddess hormone for a woman, have nourished our bodies for decades before menopause. And we now have the advances in science and the capacity and the capability to allow for safe hormone therapy during and after menopause in order to improve quality of life and allow functional and optimal aging. Now, also as a conclusion to this podcast episode, and I don't think I've said this before, but I want to clarify it here. Please do not confuse estrogen or progesterone receptor sensitive breast cancer as being a breast cancer caused by estrogen or progesterone. Because unfortunately, that is what's happening with millions of women diagnosed with breast cancer years after menopause. Women who have never used any form of hormone therapy in their life after menopause, they're told, oh, well, estrogen did it. Well, how did estrogen do it if I didn't have any estrogen? When the WHI study findings were released in 2002, it marked a pivotal moment in a shift towards abandoning hormone therapy for menopause completely. Yes, it is true. There was a decline in breast cancer incidence in the first few years. However, breastcancer.org, as well as many other reputable organizations, record a steady increase in breast cancer incidence of 1% per year from 2012 until 2021. And here's the thing. The increase in breast cancer risk reported by the WHI study in 2002 was only present in the users of Primpro. This type of hormone therapy involved equine, pregnant mare urine in a pill form combined with medroxyprogesterone acetate, a progestin, not progesterone. This information that Primpro increases breast cancer risk by 26%, which was relative risk. Absolute risk increase was 0.13 to 0.138. This information was sensationalized, and estrogen was immediately deemed dangerous. The dangers of estrogen and hormone therapy for menopause became common knowledge. It spread like wildfire. 2 years later, in 2004, the findings of the second arm of the WHI study were released, showing that women who took estrogen, only the equine estrogen, without any progestin, these women had a hysterectomy, so they didn't require progestin, they were protected from breast cancer. They had a decreased incidence of breast cancer by 26%. Well, guess what? There was no hurrah, estrogen is great for you, we should avoid progestins at all cost. I guess that would have been a dangerous message, as progestins are in millions of birth control pills. So the medical community and women alike remain oblivious to the fact that the use of estrogen only without progestin could be protective, raising the question of whether the increase in breast cancer seen with the other arm of the study was actually due to the progestin itself. The majority of women using hormone therapy for menopause and after menopause still have a uterus. Therefore, in the 1990s, all of them were prescribed Primpro because Premarin alone was only for the women with their uterus removed with a hysterectomy. This would explain the initial decline in breast cancer incidence in the first few years after the release of the WHI study, because everyone stopped using Primpro. And here's the thing nobody talks about, but we should really think about it. While the majority of menopausal women continue to live without any estrogen in their bodies, they are likely allowing a continued and persistent interaction between their hormone receptors, which they have had and had developed for 4 decades in their bodies due to the abundance of estrogen before menopause, and the endocrine receptor disruptors. As long as that will keep happening, the breast cancer incidence will continue to rise. So The protection supposedly provided by abandoning hormone therapy after menopause did not achieve its intended goal, which was decrease the risk of breast cancer. So if hormone therapy was so dangerous that everybody stopped using it, the doctors stopped prescribing it in 2002, nobody for the past 20 years got it, or the women who were brave enough to get it were, oh my God, they were very, very courageous, right? Braving breast cancer. Well, guess what? None of the women that decided not to use hormone therapy were protected for breast cancer. Not using hormone therapy did not guarantee protection or decrease risk. And that is because we have been looking in the wrong place. We continue to blame our hormones when hormones, and especially estrogen, progesterone, testosterone, are not to blame for causing breast cancer or increasing breast cancer risk. It is true that breast cancer is fearsome. 30% of newly diagnosed cancers in women are breast cancer. Breast cancer is the most common diagnosed cancer in women. It also used to be 10% of all the breast cancer was in women under 50. It's now 16%. So more and more women are diagnosed with breast cancer at a younger age. That's got nothing to do with their estrogen. It is true that 2/3 of breast cancers are diagnosed at a localized early stage when the cancer has not spread. And this makes the breast cancer highly treatable with the possibility of achieving complete remission at 5 years of over 90%, which means at that point, the cancer is likely cured. Again, breast cancer is not a death sentence, but it's an emotionally charged cancer. Lung cancer, it's almost equal to a death sentence, and it is the most deadly cancer in women, killing more women than breast cancer, ovarian cancer, and uterine cancer all combined. And the next deadly cancers are the colorectal and pancreatic, the digestive cancers, and liver cancer, which is on the rise. And guess what? It is not our hormones. It is what we eat and drink every day. It is what we force our liver and pancreas to digest and to process, and what we force our colon and intestine, and finally our colon, to eliminate, which gives us these cancers. It is our contaminated, polluted environment overcoming our body's ability to heal and avoid permanent damage caused by all the chemicals we get exposed to, all the pesticides, all the radiofrequency radiation, which is a form of non-ionizing electromagnetic radiation generated by all the cell towers that are everywhere, and our Wi-Fis. That is what's increasing our risk of cancer. And I close here, and I'm leaving you to think about this a little bit. We might have sacrificed our health for the sake of modern amenities and convenience. So please muse and ponder on all these thoughts and beliefs and theories, which are not just mine alone, but they are shared by many, many others. Again, thank you for listening, and stay tuned. I will keep you posted on when I launch Substack and what I will talk about there. Thank you for trusting me with your time, and thank you for listening to today's episode. If the content I provided wowed you, was helpful and valuable to either you or someone close to you, please do me a favor and leave me a review. I am very open and welcome any kind of feedback as well as suggestions on any content ideas. So please forward those suggestions to Jessica, my patient care coordinator, through our website, herabeautyandwellness.com. And I look forward to our time together next episode.